I'd love to talk about dialysis patients and dialysis alone, but it doesn't work that way in the setting of chronic kidney disease. I think we need to sort of get ourselves ready and understand what's going on the CKD side of things and then relate it to the dialysis. I'm going to relate it to dialysis as much as I can, but it will obviously be a general nephrology talk. And I bet you will probably feel it's necessary to learn and know these things when you take care of your dialysis patients and when you refer to more transplant and other things. So this is a real case. About 20 years ago or so, I was doing a study. I'm interested in nutrition. I'm working on sarcopenia, people who lose weight, don't have good physical performance. And we have a study where we're giving nutritional supplements to individuals during dialysis. So I got a call from the coordinator and said, I have a patient, 50-year-old diabetic, on dialysis for a long time, referred for the nutrition supplement study. Needs the DEXA for body composition, albumin is low. Normalized protein catabolic rate is low, pre-albumin transferrin are low, fits into the study, perfect. And I said, why are you calling me? This should be a pretty easy process. But she said, I cannot do the DEXA management, which is the primary outcome, because she weighs 140 kilos. I'm not saying this is something, it happens. And unfortunately, at that time, the machines were not allowed for large-size individuals, so we couldn't do this study for her. But if you were to look at the patient without really seeing the patient, without weighing the patient or looking at the body mass index, you would have said this patient is actually malnourished versus a patient that is actually overweight. And I'd like to put this into your minds that obesity is a form of malnutrition. It's just overeating rather than undereating. So conceptually, when we talk about malnutrition, people always think about we don't eat as much, but malnutrition could be overeating too. It's inappropriate nutritional management or state in general. So what I'm going to do is I'm going to discuss a couple of things. In order to really understand how you're going to treat obesity, you have to understand why it happens, who it impacts on, how does it develop, what are the comorbid conditions that come along with it, and what are the things that you're trying to do. So a substantial portion of the talk will be giving you some basic information about how common obesity is, what leads to obesity in general, what are the complications associated with it, and then, how does this relate to the setting of chronic kidney disease? And then finally, the rest of the talk, probably half over to maybe 1/3, will be about treatment and its relationship. I'm not going to talk about transplantation. I think I'm just going to show you a couple of slides so that you understand. But transplant and obesity, that's a totally different thing. I just want you to know. So how do we classify obesity? This is primarily done by body mass index. It's a very crude test. It's actually very non-specific, prone to a lot of problems, but that's what we do worldwide. There are different ways of really assessing the obesity and its complications, but in general, for general public, what we do is we use the body mass index criteria for three things: class 1, class 2, and class 3. Of course, there are other classes, but they're not defined as like class 0 or anything. So normal body mass index is 18 to 25. In the general population, although you have to understand there are some differences in ethnic backgrounds and where you live in the world. Asians have a much smaller body mass index and size, so it doesn't really reflect. So I'm going to be talking about the Western population here. If you're overweight, it's sort of unclear. Without going into too much detail, I am at an age that this overweight is actually a good weight for me. Studies have shown that I'm not going to tell you what my age is, but at my age, I definitely don't fit into the young generation where you have this normal weight of 19 to 25 as the expected, or I would say prognostically the most preferred. The overweight category is actually more preferred for people who are over the age of 50. That's not considered, overweight is not considered to be a major metabolic comorbid or morbid condition. And then we go into obesity, which some people say obesity and then severely obese. The threshold for that is 34.9, less than 34.9, greater than 35. And then when you go into the severely obese, you have two classes, which is 35 to 40 and then 40 and above. So that's a classification. Of course, you should always know and consider this. We use these classifications and categorization primarily for ease of talking to the individuals, defining some epidemiological data. But in general, the risk of obesity and problems associated with obesity are a continuous process. So to tell you the truth, someone who has a 35.5 BMI versus someone that has 34.5 is not much different from each other, although they're class 1 and class 2 or whatever, overweight or severely obese. So that should be kept in mind. It's a global problem. This is a slide from WHO many years ago. It was back in 2000. This is the slide. As you see on the scale on the left, as the color yellow turns towards red, there's more obesity in the world. And in over 10 years, this is what happened. If I were to give you a 2022 update, you will see that it's even more darker red in certain portions of the world. The thing that's really important for me here to mention is, I think this is the pointer. Obesity, yeah, it's prevalent here, very common here, but it's also common in Africa, It's not like, it's a problem that's associated only with individuals living in the Western world. You have problems in other parts of the world. Actually, obesity here is not defined as red, but you may know that obesity in diabetes or prediabetes is the #1 fast rising morbid condition in India. They are likely going to be the highest body mass index compared to that region in the next 10 years or so. It's a huge problem in that part of the world. So you have to understand that it has global implications. And then the most important thing that people have to understand is that when we think about obesity, practically speaking, it's very hard to communicate to the individuals like, how does obesity lead to problems? How do you really define? When you talk to someone who has risk, and by definition obese, what do you tell them? What's going to happen? And again, you have to understand that people don't die because of obesity. Remember that death certificates in the dialysis unit? People die, and you never have nutrition, malnutrition, obesity as a causative factor. People die, complications associated with obesity. So you have to take obesity as a risk multiplier. So it puts people at risk for other problems that are more deadly. And that's the most important concept you have to keep in mind. When you talk to your patients, when you tell them, hey, I want you to lose weight because it's important for you, because it increases your risk for X, Y, and Z. And if you do those, you'll feel better. You'll live longer. So that's the conceptual thing. And I think that's a very important nuance that we have to keep in mind in our practices. This is a very recent slide, actually, from the World Health Organization. It's a global burden of 87 risk factors in 204 countries and territories between 1990 and 2019. So what they're doing is, in the first part over here, you have to follow me here. I'm sorry, it's a busy slide, but I've got to go back. Here what you're seeing is the list of risk factors actually in 1990 from the highest to the lowest. As you can see in this list of these multiple markers, number 16 is high body mass index. You see that at the very bottom. In 2020 or 2019, in 30 years, it has actually risen from here all the way here. So it's 5 most important risk factor in terms of disability-adjusted life years. That is, how much life years it's costing people. So on the top is actually, interestingly enough, for kidney disease, high blood pressure. That's number 1. And then number 2 is smoking. Number 3 is diabetes, high plasma glucose, which is also associated with obesity. And then low birth weight, which seems to be a problem globally, still continues. But 5 is overweight. So it puts people into risk. Another way of looking at this is this slide, the same thing. And this is showing from the top to the bottom in terms of the worst problems causing death over a certain period of time, and then how much they increased compared to 30 years ago. And again, if you look at it, high body mass index sits here. The darker the pink, the more exponential increase in the risk of death or being a risk factor for death compared to anything else. So globally thinking, unfortunately, obesity, whatever the cause is, it leads people to die of multiple reasons. And it's become one of the most important problems that we see over the last 3 decades. And it does have some implications for patients with kidney disease too. Because if you look at the dialysis patients who are starting dialysis, incident dialysis patients, their average body mass index is greater than 32. So they automatically qualify for class 2 obesity when they start dialysis. Now, we will discuss what that means, what are the implications in a dialysis population versus before, but I will tell you that's a pretty high number. And again, when I started, when I gave my talk for the previous conference 2 decades ago, actually I was talking about undernutrition, people not being able to sort of deal with the catabolic effects of dialysis and everything else. And then when I talk about this now, we talk about a group of people who are actually obese and should not have any catabolic issues or undernutrition, not being able to eat issues. The other thing that we have to deal with is you want to go back, as practical as nurses are, you want to go back and say, I'm going to figure this out in my dialysis unit. Because that's what you do. You go back and you apply it to the clinical practice. And I'll tell you, I don't have a solution for you to be able to go back and say who's really obese, who's got the nutritional problems or not, because we really lack a cadre of reliable nutritional assessment tools.